Let's talk about accelerated automaticity rhythms. There's premature contractions. Premature contractions can be atrial, junctional, or ventricular in origin. Premature atrial contractions. To diagnose premature atrial contractions, we need to consider normal sinus rhythm. The consistency of the R2R interval allows the prediction of the timing of the very next QRS complex. However, if a beat of atrial origin occurs early, it is termed a premature atrial contraction, or PAC. Now, these are often followed by a compensatory pause. Therefore, what you should see is the first R2R interval is short and the next R2R interval is longer. In the otherwise healthy patient, premature atrial contractions, PACs, are usually a normal finding. However, the clinical context is terribly important. Exactly the same arrhythmia with a new onset immediately after cardiac surgery may have more sinister significance. In the operating room or the ICU, the development of an increasing frequency of premature beats, especially if they are multifocal from different regions of the atrium, or they're junctional or even ventricular premature beats, this is an ominous occurrence, and an arrhythmogenic milieu must be excluded. That is, the milieu, the environment immediately around the atrial myocytes, may be one that predisposes to arrhythmias. In some patients, the PACs are related to anxiety, or excessive caffeine, or nicotine from cigarette smoking. They may be related to alcohol, and sometimes to recreational drug abuse such as cocaine and amphetamines. The impact of vaping on PACs and PVCs is yet unknown. In a minority of cases, the PACs are a manifestation of serious underlying disease, heart failure, myocardial damage, cardiomyopathy, or digoxin toxicity. Usually, no treatment is necessary other than abstinence from the provoking stimulus as listed above. If this does not work, then small doses of beta blockers or calcium channel blockers, such as verapamil, or a sedative such as diazepam, are occasionally indicated. Here we see how the premature atrial contractions on the ECG relate to the mechanical output of the left ventricle as seen in an arterial line. And here we see a premature atrial contraction on the EKG, which gives a smaller systolic peak followed by a compensatory pause. Now, this is an example of manipulation arrhythmias. These occur when the surgeon picks up the heart during heart surgery. Irritation of the atria by manual manipulation can cause premature atrial contractions, and this trace is a good example of the arrhythmia's effect on hemodynamics, particularly left ventricular filling, left ventricular stroke volume, and ultimately its effect on cardiac output and blood pressure. Now let's consider this condition, wandering atrial pacemaker. In this condition, the impulse can arise from the atria, the sinoatrial node, or the atrioventricular node. This arrhythmia is usually due to excessive parasympathetic activity. It is often asymptomatic and relatively benign. It rarely requires any treatment. A very small number of patients may have ischemic heart disease or digoxin toxicity, so work through the arrhythmia checklist to exclude serious causes. It may progress to other atrial arrhythmias. In the examples shown, note the very variable P wave size, shape, and even direction. Now, moving on, let's consider atrial flutter. It's a very common arrhythmia. This arrhythmia may be due to one or more ectopic foci, but often it is caused by a re-entry mechanism. The atrial ectopic foci generate impulses at 220 to 360 beats per minute, and each of these is usually associated with an atrial contraction. This rapid atrial rate is seen on the ECG as flutter waves or large F waves, and examples are shown. This arrhythmia has a baseline with a sawtooth appearance. The ventricles cannot keep pace with this fast rate, and commonly there is some associated degree of AV block, at least 2 to 1, but it may be 3 to 1 or even 4 to 1 block. The degree of block is usually consistent, although it may change abruptly from a manageable 3 to 1 to an alarming 2 to 1. It is essential to avoid any interventions which may reduce the degree of block, as an increase in rate, which we call rapid ventricular response, can seriously compromise ventricular filling time such that cardiovascular collapse may ensue. The symptoms of this arrhythmia depend on the degree of block. Both a very high and a very low degree of block may be associated with reduction of cardiac output and blood pressure. Atrial flutter may be caused by ischemic heart disease or heart failure. Any process that damages or distends the atria may cause atrial flutter, as may an increase in sympathetic tone. Other common causes are rheumatic heart disease and thyrotoxicosis. Because the atria contract normally, atrial flutter does not usually cause thromboembolic complications, such as the ones we see associated with atrial fibrillation. The treatment is that of the underlying condition. If this has been addressed and the patient remains in atrial flutter, then digoxin or electrical cardioversion are options. Atrial flutter usually cardioverts easily at low energies, and in the absence of mechanical distension of the atria, will usually cardiovert easily at low energies as long as we have the absence of damaging stress on the atrial myocytes. Atrial enlargement can make successful, long-lasting cardioversion to sinus rhythm difficult to achieve. Now, moving on again, a very important topic, atrial fibrillation. This arrhythmia has similarities to atrial flutter. It may also be due to ectopy, but it can be caused by a re-entry mechanism. The atrial ectopic foci generate impulses at greater than 360 beats per minute or more, which is way too fast to generate a coordinated atrial contraction. Atrial fibrillation may be associated with small waves, little F waves, the appearance of either coarse or fine undulations in the baseline. However, the baseline may be flat, and the only indications of atrial fibrillation may be the constantly varying R2R interval in the EKG. Once again, the ventricles cannot keep up with this fast rate, and there is an inconsistent degree of block. This manifests as what we call an irregularly irregular ventricular response, which may nevertheless be very rapid, and our old foe, the rapid ventricular response, may occur at any time. The difference between the ventricular rate and the radial artery rate is referred to as a pulse deficit. That is, in fibrillation, the heart rate can be so fast that some contractions occur with an empty ventricle, and so an electrical event may not be associated with a pulse at the radial artery. Some of the symptoms of this arrhythmia are related to the loss of atrial augmentation of ventricular preload, and this is referred to as loss of atrial transport or atrial kick, with a reduction in ventricular preload of 15 to 20%, and this may be associated with a similar reduction in stroke volume, cardiac output and blood pressure, especially in elderly patients or those with a very stiff left ventricle. I do, however, want to really emphasize, though, that most of the decrease in stroke volume, which occurs in fast atrial fibrillation, is due to a decreased duration of diastole, which decreases diastolic filling time for the ventricle, much more so than the loss of atrial transport. Atrial fibrillation may be caused by ischemic heart disease or heart failure. Any process that damages or distends the atria may cause atrial fibrillation. Other causes are rheumatic heart disease and thyrotoxicosis. Do not forget to use the arrhythmia checklist, especially for AFib of recent onset. Because the atria do not contract during atrial fibrillation, it is associated with the development of atrial thrombus in the left atrial appendage, with consequent thromboembolic complications, and so this condition requires anticoagulant prophylaxis of thromboembolic complications requiring anticoagulation. The treatment is that of the underlying condition. If this has already been addressed, then synchronized cardioversion is an option. Atrial fibrillation does not cardiovert easily, particularly in the presence of mechanical distension of the atria. Digoxin is used to slow the ventricular response rather than being an intention to cardiovert. Atrial fibrillation is a massively important subject. Of note, never cardiovert atrial fibrillation until somebody excludes the presence of thrombus in the left atrial appendage prior to an attempted cardioversion. Thank you for listening to this presentation. Welcome back. In this video, we're going to consider how to pace a serious bradyarrhythmia using the ZOLL R-Series Advanced Life Support Module. This is transcutaneous pacing. We will use the ZOL module several times in these arrhythmia videos, and you must become very familiar with it or with your hospital's alternative. However, you really must read the online user manual. These devices are really incredible machines, and they can make your life so much easier during an emergency resuscitation. The online manual and familiarizing yourself with the details of this machine can provide massive amounts of help. The basic chest pads for delivering a pacing shock are hands-free pacing chest pads, but these will only pace if there's also 3 separate conventional ECG monitoring electrodes attached to the patient. Now, if you're lucky and your institution provides the one-step pacing pads, then these will monitor the ECG and pace the patient simultaneously, but the hands-free chest pads will not. When you've attached the patient to the EKG, check the rhythm on the screen and ensure that transcutaneous pacing is still required. Turn the selector switch to pacer and ensure that the milliamps output equals 0 milliamps is selected. This value will appear on the screen. Whatever rate you have on your screen, set the pacer rate to 10 to 20 beats per minute higher. If the rate is profoundly low, select a pacer rate of 100 beats per minute. Pacing stimuli will appear on the EKG on the screen. Ensure they appear only in diastole, otherwise there is a technical error and the machine is not sensing the patient's own spontaneous QRS complexes. Check the chest pads are making good contact. Now, increase the output in milliamps incrementally until capture occurs when a widened QRS, which usually looks very different to the underlying rhythm, just like that generated by a permanent implanted pacemaker. The striking development, of course, is QRS complexes which are faster than the underlying bradyarrhythmia. Give the patient a few minutes of good perfusion and check that there is a pulse, and then check that there's a blood pressure. And while you are incrementally increasing the current, you have somebody feeling a pulse to let you know when a pulse returns. After a period of stability, we need to determine pacing threshold. Decrease the output in 2 milliamp intervals until loss of pacing occurs. This then is the pacing threshold and is usually in the 40 to 80 milliamps range. Now we want to increase this current for a safety threshold, so we're going to add 10% to our pacing current above the pacing threshold. This is the optimal pacing output. Now, regard the 4 to 1 button. This may be depressed any time to briefly pace at 1/4 of the prescribed rate to interrogate what is happening to the underlying rhythm, that is the rhythm underneath the pacing complexes. Welcome back. In this video we're going to talk about premature ventricular contractions, also known as PVCs. They're very common. The QRS morphology of the premature ventricular contraction is usually wide and bizarre, with ST segment depressions, and the T wave is usually in the opposite direction to the QRS. This is the T wave to QRS discordancy. But they are not necessarily always sinister. Premature ventricular contractions, however, may be indicative of underlying heart disease. Let's talk about premature unifocal ventricular contractions. The QRS morphology of the premature ventricular contraction is usually wide and bizarre, as mentioned earlier. In this situation, the clinical context is important to assess the significance. Many patients with stable chronic cardiac conditions have PVCs. Their rhythm tends to be stable and usually well tolerated, and the PVCs are considered benign. However, exactly the same arrhythmia immediately after, say, a myocardial infarction or cardiac surgery may have a much more sinister significance. In some patients, the PVCs are related to excess sympathetic activity due to pain, anxiety, or excitement. All types of ventricular arrhythmias may be caused by ischemic heart disease, cardiac failure, cardiomyopathy, myocarditis, hypokalemia or hyperkalemia, digoxin toxicity, or hypoxia, acidosis, or excess parasympathetic activity. So refer to this, very important arrhythmia checklist. A ventricular ectopic beat occurs early, so it is termed premature. This is often followed by a compensatory pause. Therefore, the first R2R interval is short and the next R2R interval is longer. For ventricular ectopic beats at less than 5 per minute, usually no treatment is necessary other than the abstinence from pro-arrhythmic stimulants or drugs. More frequent ventricular ectopics may be the precursor of a life-threatening arrhythmia, and they will require treatment, usually to treat the underlying cause. If there is no obvious underlying cause, or if that cause is simply not amenable to further treatment, an antiarrhythmic drug may be used. The outpatient may be treated with oral antiarrhythmic agents, but our inpatients will generally require intravenous antiarrhythmic drugs such as amiodarone or lidocaine. Now, let's move on to something more sinister: premature multifocal ventricular contractions. The comments just made about unifocal ventricular ectopics pertain to these arrhythmias also, but multifocal arrhythmias indicate a more generalized myocardial damage and more sinister cardiac disease. Multifocal ventricular ectopics and ventricular bigeminy or trigeminy are therefore more ominous than unifocal PVCs. Now, the particular worry is the R-on-T ectopic. It is extremely worrying because sudden ventricular fibrillation may occur at any time. The occasional patient exhibits chronic multifocal ventricular ectopics. If these arrhythmias are not baseline for the patient, that is, if you have reason to believe that this is a new development, they must be treated promptly, as they may be the precursor of a life-threatening arrhythmia. Treatment is aimed at the underlying cause, and refers again to this arrhythmia checklist to my right. Now let's talk about ventricular tachycardia. Ventricular tachycardia is a malignant, wide QRS complex dysrhythmia which is intrinsically unstable. It may or may not be associated with a pulse. That is, it can be an arrest rhythm or it can be an output rhythm. Commonly, the cardiac output and blood pressure are absent or severely compromised in ventricular tachycardia, abbreviated to capital V, capital T. This decreases coronary perfusion pressure and coronary blood flow. As the myocardium becomes more ischemic, ventricular tachycardia degenerates into ventricular fibrillation. Ventricular tachycardia can sometimes generate an adequate cardiac output and blood pressure, and the patient may remain awake and alert. Nevertheless, this rhythm is potentially very unstable, and ventricular tachycardia with an output is usually a very temporary phenomenon. It usually degenerates to ventricular fibrillation for electrophysiological reasons, even if the myocardium is adequately perfused. Consider in these situations, does the patient have ischemic heart disease? Is there hypoxia, acidosis, hypercapnia, hypokalemia, or drug effects? Also, any imbalance in sympathetic to parasympathetic innervation of an already compromised heart may precipitate ventricular tachycardia. A diagnosis of ventricular tachycardia requires 3 consecutive fast ventricular ectopics called a run of VTAC. The rate of VTAC is usually 130 to 230 beats per minute. The rate to establish a diagnosis of VTAC is greater than 120, but we usually see it at a rate of 130 to 230 beats per minute, and the R2R interval is irregular. This helps distinguish it from a supraventricular arrhythmia, in which we see a consistently narrow QRS complex. It is regular and is usually, at least initially, stable. Conventional wisdom is as outlined in the Advanced Cardiac Life Support Adult Tachycardia with a Pulse algorithm. Ventricular tachycardia is always wide complex, so ventricular tachycardia with inadequate output is a life-threatening emergency and is treated with immediate electrical cardioversion, exactly as for ventricular fibrillation. And ventricular fibrillation and ventricular tachycardia share the same ACLS algorithm. Ventricular tachycardia with an adequate blood pressure and cardiac output can be treated by chemical cardioversion, which inevitably takes a little longer. Any new onset of arrhythmia requires the use of the arrhythmia checklist. Particularly important are hypokalemia, hyperkalemia, or other electrolyte abnormalities, or severe imbalance of the ratio of sympathetic nervous system to parasympathetic nervous system innervation. A special type of ventricular tachycardia with a gradually increasing and then gradually decreasing QRS amplitude is called polymorphic ventricular tachycardia, or torsade de pointes, and can be treated with magnesium and amiodarone. Now, let's move on to a cousin of ventricular tachycardia, ventricular fibrillation. And there's a big overlap between similarities in treatment of these two conditions. Ventricular fibrillation is the commonest mode of cardiac arrest in adults, and there is loss of cardiac output and blood pressure. It is an immediately life-threatening arrhythmia, requiring a very rapid response. The ECG shows completely uncoordinated, random or chaotic activity. Fibrillatory waves may be seen at greater than 300 beats per minute, but determining the rate is impossible, so don't even try. It has no relevance. The waves may be large and coarse, mimicking ventricular tachycardia, or so fine that their baseline looks like asystole. The causes are ischemic heart disease, again, hypoxia, acidosis, hyperkalemia, hypothermia, cardiomyopathy, myocarditis, drug effects or drug interactions. Before diagnosing ventricular fibrillation, ensure the absence of a pulse. Check the ECG leads to exclude lead disconnection. Faulty leads or external movement and interference can easily mimic the appearance of ventricular fibrillation. So, if you see the sudden onset of ventricular fibrillation, check immediately for a pulse. Before diagnosing asystole, consider very fine ventricular fibrillation. It may be that what looks like asystole may actually be very fine ventricular fibrillation, which you can defibrillate electrically. Treatment is as recommended in the ACLS protocols. As often happens in both the community and in the hospital, a patient can be found unresponsive, and so we must first do basic life support, and if necessary, proceed swiftly to advanced cardiac life support. Let's talk about the treatment of ventricular fibrillation and ventricular tachycardia. This is all about priorities, priorities, priorities. If an apparently obtunded individual gives you concern, initiate basic life support. Try to arouse them first. Any response to voice? And then increasingly, is there any response to forceful touch or firm shaking? If no response, call for help immediately. All healthcare providers should check for normal breathing. If so, the patient probably has a pulse, and it may be rapidly getting weaker. If the patient is not breathing, quickly check for a pulse, but do not take any longer than 10 seconds. If no pulse, then we have cardiopulmonary arrest. Now let's take a time out here. So, this patient is going to die very soon if not treated correctly. Our first priority is, let's keep the patient alive until treatment can be given. He will only survive if his heart and brain get some blood flow. So start high quality chest compressions, which if done really well can give him a cardiac output of 12% of normal. But this sounds very low, but it's much better than no flow at all. The patient's best chance is if he has VFib. So our second priority is, as soon as a defibrillator or automatic external defibrillator arrives, you must defibrillate stat. First attempt at an energy level of 120 to 200 joules, and if a pulse returns, then great. If not, you must still keep the patient viable with really great chest compressions. Give a high energy shock as soon as possible. If there is still no pulse and chest compressions are not getting enough blood to the heart, that is, coronary perfusion pressure, or CPP, is just way too low. How can we improve this? Well, we can redirect blood flow from non-vital organs towards the vital organs, such as the heart and the brain, by giving epinephrine. Priority 3. Give epinephrine 1 milligram IV. Note that all IV drug administration is followed by 20 mL of normal saline flush, and then raise the IV access arm for a few seconds to allow it to drain in. Epinephrine must often be repeated, but give the epinephrine at least 2 minutes of chest compressions to reach the myocardium before the next shock. Repeat epinephrine approximately every 3 to 5 minutes, and the defibrillations are repeated until ventricular fibrillation stops and a rhythm which generates a pulse returns. The newly introduced high-quality CPR recommendations are absolutely essential, and my interpretation of this in summary is fast, furious, and almost unrelenting chest compressions. Using a biphasic defibrillator, administration of a shock of 120 joules is recommended initially, and then escalate rapidly to 200 joules, and that is repeated thereafter. The coronary perfusion pressure must be consistently greater than 20 millimeters of mercury, that is, the pressure in the arterial system in between chest compressions. If there is no response to several rounds of epinephrine and administered shocks, a powerful antiarrhythmic drug such as amiodarone is administered at a dose of 300 milligrams if the patient is pulseless, as in this case. But in the context of a patient who has a pulse, the antiarrhythmic dose of amiodarone is only 150 milligrams. Your ability as a physician to manage this situation well is profoundly important. This is your responsibility. Each and every physician must be able to do this well. I cannot emphasize this enough. This is a common life-threatening emergency, perhaps the commonest cause of death in our community. This is a defining competency for each and every physician, and you must be very confident in your ability to manage the patient in ventricular fibrillation or ventricular tachycardia. Thank you so much for listening. See you in the next video.